Okay, so we talked about fluid balance. Now we're going to talk about sodium. Sodium is one of the big electrolytes that's in our body that is very important. It plays a huge role in our fluid balance. So we're going to talk specifically about some sodium levels. Okay, so this is some of the levels that you guys are going to need to know. So just commit these to memory, get them in there. You'll have to know them because they're very, very important. It's something you're going to look at every time you go to work and make sure that your sodium levels are good. So remember, normal levels of sodium is 135 to 145. Now, the reason sodium is so important because again, it regulates our fluid volume and helps maintain our blood volume. So it actually in our bodies, in our kidneys, we have these little, I always think of them as little worker guys in there that are going, hey, decrease your sodium, increase your sodium. So we have these things, we call them chemoreceptors, and they're inside our kidneys. And so when our sodium levels get too high or too low, it triggers different kinds of hormones, antidiuretic hormone, aldosterone, lots of different hormones in there to start increasing urinary production or decreasing urinary production based on what these lab values are. However, sometimes those little guys in there that are supposed to be regulating all that stuff take a vacation and they're not doing their job like they need to. So that's why this can happen. So what happens with sodium? I always think of sodium as being the brain, and sodium affects the way we think, and it just causes lots and lots of confusion. So sodium levels stimulate that conduction of our nerve impulses, but it mainly is for fluid volume. So hyponatremia. Natremia just means sodium. So hypo means low. So that means we have a sodium level of less than 135. We're going to classify that as hyponatremia. So if we have hyponatremia, so in my bloodstream, we drew my blood out of my vein. We can't draw it out of our cells because our cells are too tiny. So I drew my blood and I got 134. So that tells me that I have hyponatremia. So that means I don't have enough sodium. So my sodium level is going to be really low. So where is all my sodium? So it's hypo. So where did all of my sodium go? So my sodium is over here in my cell. And where does Willy water want to go? Wherever the sodium is. So if the sodium is in the cell, where's the water going to go? It's going to go into my cell. And what's going to happen to my cell? It's going to get big. So it's going to get big. It's going to get hypo. It's going to get big. Okay? Now, what causes this? Diuretics. So sometimes we put patients on diuretics. We assume, we send them home. Everything seems to be going good. But unfortunately, they're losing too much sodium. So that little guy in there that took the vacation, he's overworked because we've given them a diuretic. And now he just can't keep up with all of the changes that are happening in the kidneys. So he's letting way too much sodium go. So our sodium levels are getting low. GI loss, that's going to be vomiting, diarrhea, if we got NG suctioning, that kind of thing, if they're profusely sweating. If we give them hypotonic solutions in the beginning, I really don't expect you to understand this, but this is called antidiuretic hormone. And sometimes, remember I told you sometimes that they regulate, those little people in there regulate that the level by increasing antidiuretic hormone or increasing aldosterone or decreasing aldosterone. I don't expect you to really know that at this point, but I just want you, I think you've probably heard that in your anatomy and physiology classes, but this is where that antidiuretic hormone goes away. It just doesn't do what it's supposed to be doing, so we're losing too much sodium. And this is where we can get burns or wound drainage. Sometimes you will have a patient that will come in that has massive amounts of wound drainage. So they're getting massive amounts of fluids that is coming out, and we're putting them into a deficit, okay, because they're losing too much fluids. So it's hypo, so they're losing those fluids, okay? Now, signs and symptoms. So if they don't have enough sodium, they've lost it for whatever reason. Some of the reasons that this can happen, or what you're going to see with them, is sometimes anorexia just means lack of appetite. It doesn't mean anorexia nervosa is actually the disease that you get that's a psychological disease of eating. Anorexia in itself just means lack of appetite. They get nausea and vomiting, weakness, like severe weakness. They get lethargy. They can't take a deep breath because the muscles just aren't working. So we start to get into what we worry about with someone who is, maybe not coherent, is respiratory arrest in somebody when their sodium get really, really low. They get confused and they get that cerebral edema, because remember, that blood vessel doesn't have much sodium in it. So all the sodium is over here in the cell. So if my Susie salt is in my cell, Willy water's going to follow. So Willy water comes into my cell, blows my cell up big, okay? So that causes cerebral edema, okay? Then we get muscle cramps, and this can eventually lead into some seizure activity. So we really don't want our patients to get to that point. We would like to catch this prior to. That's why it's really important first thing in the morning when you come in as a nurse, you look at those 5 a.m. labs and see, what do I need to do today? Am I going to need to notify the provider that their sodium level is 123? They've had a decrease in their altered state of consciousness. They were pretty, with it yesterday, and today they're a lot worse. So we need to know those kinds of things so we can treat that appropriately. So treatment, daily weights, just like we would do for fluid volume deficit or fluid volume overload. We're going to check those sodium levels. Every morning that needs to be checked. We need to know what's going on. We're going to increase their sodium intake, especially if it's low. We're going to give them an IV. We're going to make sure that those IVs are going. If their sodium level gets super low, they may go ahead and institute seizure precautions just in case that level gets too low and they start to have a seizure. And we're going to give hypertonic fluids. So hypertonic fluids is going to have extra salt in it. So if we put extra salt inside my blood vessel, where's Willie going to go? I got salt in here. He loves Susie, so he's going to pull out of my cell and make my cell smaller down to a normal size. So he's not going to be big like this. He's going to be normal size. Okay, so we're going to give them that hypertonic solution. Now, always make sure we're watching our patients for all the fall risk, seizure precautions, suction, all that kind of stuff if it's ordered that our physicians think that they need it. So always be aware of that. Hypernatremia. This is where they have too much salt. They got way too much salt. So this is where their sodium level is going to be over 145. Okay? Now, what's going to cause that? Why does somebody get too much salt? Well, a couple of reasons. Somebody who's running a marathon, if they don't do salt replenishment while they're running that marathon, they can get into a hypernatremic state. So they sweat a lot. Fever can cause this. Someone who's really sick, somebody who is, we may see this with diabetics. Your diabetics get into ketoacidosis where their blood sugar gets super, super high, and they will go into this hypernatremic state. Burns. Not taking enough fluids, vomiting, diarrhea, because we're losing these things. So that's the causes of too much sodium. We're losing the fluid, but not the electrolyte. We keep that sodium in there. So that's water loss. That's just water loss. We can have sodium gain. So sometimes it's not a water loss problem, it's a sodium gain problem. So maybe we've given them too many hypertonic fluids. And one of the hypertonic fluids that we do a lot is tube feedings. So we don't really realize that every patient that's on a tube feeding is getting a hypertonic solution. And so they could actually get higher sodium levels because of that tube feeding. Maybe they're eating too much sodium. Cushing syndrome and then hyperaldosteronism, we're not going to really talk about that, or kidney disease. So if the kidneys can't get rid of the fluid, it can't get rid of the sodium. So we get an increase in that. So those are some of the reasons that you can get hypernatremia. Now, what are you going to see? Somebody that has hypernatremia. So if they got hypernatremia, they're going to be thirsty. They're going to have, a lot of times they'll have an elevated temperature. So you might see somebody with maybe a 99.9, 100. They're not super high, but they're just enough because their body is went into a hypermetabolic state. So it's causing that increase in that temperature. Dry mouth, sticky mucous membranes, If it gets super bad and that sodium level gets really, really high, they can start having hallucinations, irritability, lethargy, all those kinds of things. So we get that hypernatremia because, again, my blood vessel, we got hypernatremia. So I got lots of sodium inside my blood vessel, right? Blood vessel, lots of sodium. Where's my salt? Where's my water? My water's in my cell. Where is Willy water going to go? Willy water is going to come out of my cell into that space. So my cell is going to shrink up to nothing. So I've got cellular dehydration. Okay, so that's a term you may start hearing. It's a little different than just plain dehydration, but it's cellular dehydration. That's why we see this a lot in our patients that have fevers, that are really sick. We might see this in our ketoacidosis patients because it's a metabolic issue that's happening there. Okay, now what are you going to do? Well, we're going to monitor the intake and output. Is it going in, going out, all that kind of stuff. We're going to look at those sodium levels every morning when you come in to see your patients at 7 a.m. You know, that's some of the things you're going to check that very morning. Sometimes the night shift has already put it in for you, but you need to know what that sodium level is. You may need to make a phone call to the provider because they're not going to come and see that patient until 2 p.m. By 2 p.m., it's 7 a.m. A lot can change in that 7 hours. So it will be up to you to make sure you're checking those levels and getting them to the physician. We're going to restrict their sodium because they're already high. They don't need any more. So we're going to have to watch for those foods that have hidden sodium in them. And we're going to have to teach our patients when they go home. And that gets really difficult with our elderly patients that are probably eating processed foods because they're very high in sodium levels. And we're going to have to increase that water intake because we got to increase the water intake to kind of dilute the sodium that's in there. And then we're going to give them hypotonic fluids because remember the cells are shrinky, shrivel. And so we want to push that fluid with that hypotonic fluids to make that cell big. Okay, so that's how we're going to treat that. So that is how your sodium is going to work.